Okay, so welcome to the expert webinar series organized by the Sri Lankan College of Physicians in collaboration with the the Association of Sri Lankan Neurologists. Today's speaker is a world-renowned expert in epilepsy. That's Professor John Duncan. Just to introduce John to you. John Duncan is a consultant neurologist specializing in epilepsy, practicing at the National Hospital for Neurology and Neurosurgery, Queen Square, London, and at the Chalfont Centre for Epilepsy. His personal research focus is neuroimaging applied to epilepsy surgery. He was appointed Professor of Neurology at the UCL Institute of Neurology in 1998. From 2012 to 2018, he was clinical director of the National Hospital for Neurology and Neurosurgery. In 2004, he received the annual Clinical Research Recognition Award of the American Epilepsy Society. He's past president and past treasurer of the UK chapter of the ILAE. In 2005, he was elected ambassador for epilepsy and to be a fellow of the Academy of Medical Sciences. He has 462 original peer-reviewed publications and over 46,000 citations and an H index of 117. And on a personal note, he was my supervisor when I was at the National Hospital for Neurology and Neurosurgery, maybe 5 or 6 years back. All right, over to you, John.
Okay, well, ladies and gentlemen, thank you very much for the invitation to speak with you about epilepsy surgery. As Kishara Gunaratne said, we had the pleasure to have him work with us at Queen Square about 5 years ago, and he wrote a very good paper on all the complications of epilepsy surgery, something that, of course, is very important. So let's consider the size of the problem. Now, in the UK, we have a population of about 64 million people. We have 30,000 new cases of epilepsy every year, and about 5,000 of these are refractory. Half of these are focal, and we end up with about 1,000 surgical candidates per year. Now, if we translate that to the population of Sri Lanka, you would expect to have 330 new surgical candidates coming on stream every year. And in terms of prevalence, you would estimate you have 3,300 people with epilepsy who are candidates for epilepsy surgery. Now, the actuality is that in the UK, at least, and probably in many countries, the amount of surgery that actually is done every year is less than the numbers of people who are potential candidates. So there is under-referral to epilepsy surgery. Also, there is a very long pathway for people getting referred. In our hospital, there was an 18-year interval between onset of epilepsy and patients having the operation. And 47% will go into remission with the first drug, 32% with the second drug, 9% with the third drug. After that, less than 5%. So if somebody's epilepsy is not well controlled with 3 medicines, the chances of further drugs being helpful is not good. So in practical terms, people who should be referred by non-specialists to an epilepsy surgery centre are those patients who have tried 2 or 3 medications and with focal epilepsy. And also we would want to consider resection that is potentially curative before doing any kind of palliative treatment. Now, over the last 20 years, as epilepsy surgery has got more established, the threshold for doing surgery has come down. So 20 years ago, typically somebody would have at least 4 seizures per month with loss of awareness. Typically, they will not be in employment. Whereas nowadays, if somebody has 1 seizure a month, if they have adverse effects from medication, and if they're able to undergo surgery, we would put them forward as a candidate. It's important, of course, that people don't have serious comorbidities like active cancer, vascular disease, and neurodegeneration. The issue of learning disability is more difficult. I think outcomes are less likely to be so good in somebody with learning disability, and there is the question of whether the person can give consent and whether they're realistic about what can be achieved. To summarize things, for temporal lobe epilepsy, which is probably the most common operation done for epilepsy, with medical treatment, if someone's tried 2 or 3 medicines, the chances of seizure control is less than 5%. There is the morbidity from seizures, there's the psychosocial handicap from epilepsy, and there is 1 in 100 annual risk of dying from epilepsy. Surgical treatment, however, may give us a 70% chance of remission, and the risks, about 1 in 100 of a long-lasting serious morbidity like hemiparesis, 1 in 20 risk of a visual field defect that prevents driving. So the way I would summarize it is that for the typical case, the risks of epilepsy surgery is about the same as the risks of leaving somebody as they are for 1 or 2 years, but the chances of being seizures in remission is much better with surgery. So when we do the evaluation, we're looking for evidence of a single abnormality in the brain that is giving rise to the epilepsy, the epileptic focus, and we're looking for evidence of any abnormalities elsewhere in the brain. This is a complex process. It requires a well-functioning, integrated team. We need a neurologist, a neurophysiologist, neuroradiology, a neuropsychologist, a neuropsychiatrist, a neurosurgeon, and also the backup support for the patient of an epilepsy nurse specialist, a counselor, and a social worker. And the way it works is that a patient will be referred. Initially, they'll be seen in the clinic for detailed clinical review of the history and the examination. Then they'll have the basic phase 1 tests of MRI, video telemetry, neuropsychology, neuropsychiatry. Then we would review the results with the patient. We'll consider whether further tests are needed, say functional imaging or even intracranial EEG, and we would arrange for the person to speak with somebody who had had similar surgery in the past, so they knew exactly what would be involved. Now, imaging is fundamental, and it's been the development and sophistication of MRI that has really underpinned the growth of epilepsy surgery. MRI will predict both the nature and the extent of pathology, and I would say that it is uncommon to resect an area with normal imaging. Not unheard of, it does happen, but we have to accept that good results of surgery are less likely if imaging is normal. So we get a high-quality MRI scan, including a FLAIR sequence to identify cerebral lesions. We have an epilepsy protocol that's looking for underlying structural brain abnormalities. And the main pathologies would be hippocampal sclerosis, malformation of cortical development, cavernoma, dysembryoplastic neuroepithelial tumor, gliomas, arteriovenous malformation, and focal cerebral damage. These are the main pathologies that if they're focal and if they're removed, the person has a good chance of being seizure-free afterwards. Now, of course, it's important to have concordance with the clinical and the EEG data. And just because the person has an area of brain damage or cavernoma, say, that does not prove that the person has epilepsy, and it does not prove that that's where the person's seizures are coming from. So with the epilepsy protocol, it's very important to have detailed information for the radiology team, to work with a neuroradiologist, to get a 3D volumetric T1 weighted acquisition, T2 weighted axial and coronal images perpendicular to the hippocampus, 3D volumetric FLAIR or thin axial and coronal slices, and a T2 gradient echo axial and perpendicular to the hippocampus, looking for areas of microhemorrhage. So the main pathologies, well, hippocampal sclerosis. Here's a normal hippocampus on the right side, normal architecture, normal size. And here on the left, hippocampus is much smaller. Also, there's increased T2 signal in the center of the hippocampus. Now, that can be difficult to assess. A way to improve the sophistication of this is to take quantitative measurements of both the hippocampal volume, such as here, and also quantitative measures of the T2 signal with normal ranges, so we can see whether there's damage on one side or the other. We also have, from the cross-sectional areas, build up the contour plot of the hippocampus Here on the left is the normal range for left, and on the right, and you'll see that the right hippocampus is entirely normal from the head through to the body and the tail, whereas in this case, the left hippocampus is atrophic from the head the whole way posteriorly. And the T2 measures, this is the normal range shown in blue. T2 is abnormally high over this length. And this person has unilateral left-sided hippocampal sclerosis. And on the quantification, you can see that the volume of the left hippocampus, 2.26 milliliters, much smaller than the right, 2.76, a volume ratio of 82%. Also, the hippocampal T2 time is elevated on the left, 129, compared to 113 on the right. Now, the other point that is really important is if we're planning epilepsy surgery, we need to, on a hippocampus, a temporal lobe, we need to be very sure that the contralateral hippocampus is normal. If one removes one hippocampus and the hippocampus on the other side that is being left in, of course, is abnormal, if it's scarred and damaged, there is a high risk of the person having significant amnesia as a result. Other pathologies. Decembryoplastic neuroepithelial tumor here in the right parietal lobe, a meningoencephalocele, an area of herniation of brain through a cavity in the middle cranial fossa, very epileptogenic, often hard to see, and this one specifically looks for this. Focal cortical dysplasia, this high signal from the cortex down to the ventricle, this low-grade glioma here in the left amygdala causing increase in flare signal and increase in volume. A decembryoplastic neuroepithelial tumor here in the superior frontal gyrus on the sagittal scan and shown here on the coronal scans. A cavernoma with a characteristic donut appearance deep in the sylvian fissure, so in between the insula and the superior temporal gyrus, shown on these four different sequences, very characteristic appearances. Now, all of those patients had surgery, and all of them were cured by surgery to remove that part. Imaging will also show us pathologies that are more widespread and for which epilepsy surgery is not going to be helpful. Here's an example. Somebody has bilateral periventricular heterotopia lining the ventricle on the left, but also on the right. Also, they have polymicrogyria in the overlying cortex and a large arachnoid cyst. This is not a good candidate for surgery. Now, in about 25 to 30% of people, the conventional MRI scans appear normal, and a lot of work is done to try and improve MRI acquisition that are more sensitive. Now, here's an example of what is called the NODI diffusion imaging sequence. This appears normal on a T1 weighted scan, and on the standard T2 weighted image, it looks normal. On a map of diffusivity, it looks normal. An FA map, it looks normal. But on this computation of the intracellular volume fraction, it's very clear that there's an abnormality here in the left inferior temporal gyrus. This was removed, and this is an area of focal cortical dysplasia, one of the forms of malformation. So imaging is very important to understand the structural substrate. The next test we have to do is video EEG telemetry to record typical seizures with simultaneous video and EEG. We're looking for interictal epileptic discharges. Also, to record seizures, commonly we will reduce the epilepsy medicines by 50 to 75%. We analyze the video and events, looking for the likely site of onset, and we have prolonged EEG and ictal EEG, looking for sources of the focal epileptic activity.
James, you're chosen to jump.
So this girl is coming to the hospital for a period of seizures. You'll see that she's gone blank. Mother presses the alarm button. She's blank. She has these orthotisms of the left hand.
What's happening here? She's having a seizure. Okay, raise your arms up.
A nurse comes in to check them
Raise your arms up.
to assess whether they can respond, whether they can
In the
remember
top,
things.
say, person table. Right, let me just sit you there.
So she's not able to speak. She's able to
Talk to
respond to
me.
the
Can you
nurse,
look at the window?
but she can't make any noises. She can't come up with any words. The accommodants become bilateral.
Caris, can you say your name? Caris, lift your arms up like this. Just follow me if you can. Like this. Look at me. Look at my arms. Open your eyes.
She's not able to understand.
Caris, how are you feeling?
She's not able to speak.
Can you talk to me? Raise your arms up like this, please.
So this is a typical assessment done by our excellent nurses to determine whether the person is aware, alert, whether they can speak, whether they can understand. This is a very typical temporal lobe seizure. Here's something quite different. This patient is asleep. She rouses, turns over to the right. It's a very vigorous hypermotor seizure. It's very short.
Hi, good morning. How are you feeling? Lift your arms up and down.
And within a few seconds, the seizure stops. The nurse is able to interact with her. She knows who she is, where she is. She can follow the crest. It is typical of a kind of seizure coming from the front part of the frontal lobe, very different from the temporal lobe. So we record these seizures and we see how the EEG and the clinical pattern, see if that matches up with the imaging. The kind of scalp EEG pattern we might get, this is somebody with a left temporal lobe seizure, and you can see the ictal onset, a high frequency, low amplitude discharge that gets bigger in amplitude and slows down. Now the neuropsychologists are very important. They need to test the patient's cognitive function to tell us whether there is one area of the brain that is dysfunctional, whether there are widespread deficits, and also to predict the consequences of surgery. And in essence, they will focus on language, verbal and non-verbal memory, but also intellect, flexibility, literacy, calculation, visuospatial processing, attention and concentration. These tests looking at the integrity of various parts of the brain. And in terms of predicting the consequences of surgery, this is much more important if somebody has a few seizures. And I say the area that is most risk is in somebody having a speech-dominant temporal lobe resection, whereby if they function at a very high level, say if they're a doctor or a lawyer, have to use a lot of language, if they have surgery to the speech-dominant temporal lobe, they're likely to be troubled afterwards by having a decline in memory and a decline in word finding. So that has to be set against the chances of making the person free of seizures. It's important that our psychiatrists assess the person's personality adjustment. We need to know if there's any affective disorder, psychosis, or OCD that needs to be treated. We need to know about their support network. We need to know if problems are only post-ictal or if they're persistent, and if there is any comorbid psychiatric condition that needs to be treated before surgery is undertaken. Now, just to remind you about the importance of MRI findings in terms of prognosis, this is from the Queen Square series where people have had surgery and they're followed up here for 20 years. So when somebody comes around from the surgery, they're seizure free, and the occurrence of any seizure means that they're said to have relapsed. So the best group is this green line of hippocampal sclerosis. So 5 years after surgery for hippocampal sclerosis, about 60% have never had a seizure from the day of surgery, and at 20 years, it's down to about 45% are seizure-free. Never had a seizure at all. If we take other pathologies, like say DNT or cavernoma, the odds are a bit less good. We end up about 40% seizure-free at 20 years. If we take people with normal MRI, it's only about 15% of people are entirely seizure-free. So much less good prognosis if MRI is normal. Now, the other factors that take into account are if people have generalized seizures and do they have psychiatric pathology. So if people have neither generalized seizures nor psychiatric pathology, the chances of being seizure-free at 12 months is 74%, and at 48 months, about 65%. If they have generalized seizures, the chances are reduced, 49% at 4 years. If they have psychiatric pathology, also 49% at 5 years. If they have generalized seizures and psychopathology, the chances of being seizure-free at 5 years is only 1/3, 33%. Now, if we combine that with a normal MRI, people with generalized seizures, psychopathology, normal MRI, the chances of being seizure-free at 5 years is less than 20%. So these patients are not good candidates for epilepsy surgery. Now, moving on, we use functional MRI to lateralize language function, also to localize the primary sensory and motor cortex, and we have an emerging role for evaluating memory and to predict the effects of surgery on memory, and we can map into epileptic discharges by recording an EEG at the same time as the MRI. So there are various language paradigms, and these activate different parts of the brain. So, for example, auditory naming activates Broca's area in the left frontal lobe, also the temporal pole and the inferior temporal gyrus. In blue are areas of deactivation. Picture naming particularly activates the inferior temporal gyrus and the fusiform gyrus. Verbal fluency particularly activates Broca's area in inferior and middle temporal lobe. Now we're in the frontal lobe, I'm sorry. So these are all relevant because the activation, the more activation there is, the better the performance the person is doing at that task. So we know that these are functionally relevant. So if we're planning surgery to the frontal lobe or the temporal lobe, we can choose the paradigm that gives us the best prediction of what will happen should surgery be carried out. And just to summarize perhaps this recent paper we had showing the visual naming. Now, essence, if somebody uses the left inferior temporal lobe strongly for visual naming, these people are much more likely to have significant decline of word finding after surgery. So we can use this to predict exactly what will happen should that person have this surgery. Similarly with memory, we can show the parts of the brain that are activated with memory for words. Here's faces here and words here, and how much that part of the brain is used with the fMRI task will tell us what risk they run from having surgical removal. We can put these things together. Here's a coronal scan showing an area of cortical dysplasia in the right motor cortex, and the same patient with fMRI for foot and for the hand area shown in green shows us that this is exactly, this hand area fMRI is exactly where is this abnormality. Now in blue is the MRI changes associated with spikes, epileptic spikes on the EEG. And what that tells us that in this girl, who was a pianist aged 24 years old, that right in the area of cortical dysplasia, right in the motor strip, she has an area of cortical dysplasia that is generating epileptic activity, but also is one and the same place as is a primary motor cortex for her left hand. Now in this patient then, this enabled the decision with no invasive tests that doing an operation to remove the epileptic focus will give her a weak left hand. Now, she's a concert pianist. Her left hand fine movements are very important for her. The epilepsy wasn't so bad, so this gave her the decision not to proceed with surgery that would cause a deficit. Looking at it in 3 dimensions is always more valuable than in 2. Here's a different patient who has on the left side of the brain here, the front, the back, area of focal cortical dysplasia in the depths of the left superior frontal gyrus, and the fMRI shows us the motor activation from the hand controlling the right hand the right leg, and the supplementary motor area. So seeing where these are allows us to plan a surgical resection that removes the area of focal cortical dysplasia but does not damage the eloquent motor cortex. Now, in those 25% of people for whom MRI is normal, we use FDG PET, looking for an area of hypometabolism that indicates whereabouts the seizures may be arising from. We're looking for an area of, often it's quite a large area of hypometabolism that lateralizes and gives us a broad localization. Now, we don't need this if MRI and EEG are concordant. We use this if MRI is negative or if it's unclear. And this is useful in about 50% of people. And this will lead us to review the MRI and also to guide intracranial EEG. This patient we thought had frontal lobe epilepsy. We thought the MRI scan was normal. We got an FDG PET that showed hypometabolism in this area here on this axial slice, and also on the surface rendering of the image, relative hypometabolism here in the left frontal cortex, and on the statistical map, comparing this patient with 30 controls, area of hypometabolism. So then we go back to the MRI scan again, look particularly at this area, and we noticed something that we missed the first time, an area of high signal going down to the lateral ventricle, an area of focal cortical dysplasia. So this patient will then have a very restricted operation just to remove this piece to cure the epilepsy. An example in the temporal lobe, a man who has left temporal lobe epilepsy, we thought, whose MRI was normal, and there's clear hypometabolism in the left temporal lobe, so laterally, also on the view from underneath, and shown on the statistical map with this distribution of hypometabolism in the left anterior temporal lobe, laterally, and on the underside. This then allows one to go to a resection without further investigation. Another nuclear medicine technique is called Spect, or single photon emission computerized tomography. The essence here is to make an injection of a radioactive tracer that follows blood flow at the time of a seizure, when there will be a blood flow increase to one part of the brain, and then to do an interictal scan in between images when there is not going to be the increase in blood flow at the area that is giving rise to the seizures, and subtract one from the other. Now, caveats about this are that one is injecting radioactivity at the time of the seizure. It's very time sensitive, so everything must be set up in advance. There's a limited temporal resolution. It takes about 40 seconds, 45 seconds for the injected tracer in the arm to get up into the right side of the heart, through the lungs, through the left side of the heart, up the carotid arteries, into the brain and get fixed. So one is imaging blood flow 45 to 60 seconds after the injection was made, and one only gets one image from each seizure. But this can be very useful. If we subtract the ictal from the interictal image, we see an area of increased blood flow at the time that the seizure was occurring. This was removed, and this is an area of focal cortical dysplasia. Now, intracranial recordings are needed in about 25% of people who are candidates for epilepsy surgery, if it's not clear from imaging or scalp EEG exactly where the seizures are arising from. Now, this is a major undertaking. There's a risk of morbidity and risk even of mortality. We use these to record epileptic activity, also to stimulate. We record from the surrounding cortex, so we need to be very careful exactly where we place these electrodes. And putting in blind implantations, not really sure where the seizures may be coming from, is not the way to go. And we need to assess the relationship between the epileptogenic cortex and elegant cortex, be it for language, vision, motor. We can use subdural grids, subdural strips, or depth electrodes. We're moving more and more towards depth electrodes as they have much less morbidity, they're much better tolerated by patients, and in particular, the risk of infection is much less. So for a subdural grid, we need to make a large craniotomy, put in this grid of electrodes. This is 8 centimeters by 8 centimeters, so it's a big area placed over the surface of the brain. Put back the craniotomy, tunnel the wires underneath the skin, replace the bone flap, replace the skin flap, and the person is on the recording ward and we're waiting for seizures to occur. The alternative way of placing intracranial EEG with stereo approach is shown here. This is the right side of the brain, and from the clinical semiology, from the EEG, we've selected these targets: the temporal pole, amygdala, anterior hippocampus, posterior hippocampus, temporoparietal junction going into the posterior cingulate, anterior insular, posterior insular, middle frontal gyrus, SMA, superior frontal gyrus, or middle frontal cortex. These are all the electrodes that we're going to place. These are the parcellations of those parts of the brain. These are the blood vessels shown with angiography, and these are the trajectories of the electrodes placed in the brain, and we hope to be able to identify the site of seizure onset. Imaging the blood vessels is very important. The best way of doing it at the moment is with digital subtraction and angiography. One can get some visualization from a T1 weighted MRI, but it's less good. And also MRV, MR angiography will show most vessels, but not as much as this. We use software called EpiNav for planning the precise trajectories of the electrodes, in particular to plan trajectories that avoid damaging or coming into contact with blood vessels that may cause bleeding. We end up with a risk map from entry into the brain to the target, showing how close a significant artery or vein is. And this is 3 millimeters. So exactly at this point here, we're going to go within 3.6 millimeters of a blood vessel with a trajectory such as the one here. The electrodes are put in stereotactically using a stereotactic guide. And after the implantation has been made, this is how the patient's head looks. These are, rather than having a big craniotomy, these are tiny 2 millimeter drill holes with a bolt into the skull to secure the electrode. And this is how the CT scan fused with the MRI shows us afterwards exactly the location of all the electrodes. And again, another example whereby we've taken multiple depth electrodes, we fused the CT and MRI afterwards. And in this case, this patient had surgery to remove part of the temporal lobe already, and we wanted to tell whether seizures were arising in the residual hippocampus. This needed a long electrode, about 12 centimeters long, coming from posterior laterally, going anterior along the whole length of the hippocampus, ending up towards the temporal tip. And here's that electrode there. So accuracy is very important. With the depth electrodes, we get exquisitely good recordings of the EEG. Here's a typical seizure onset in the right hippocampus in this one electrode, pinpointing the site of seizure onset. Now, when it comes to make resections, we need to plan the resection very carefully to remove the part of the brain that is giving rise to the epilepsy, but to avoid causing damage to eloquent cortex. This is on the right-hand side. This man has a lesion just here, an area of dysplasia. But also, you can see the little red dots here. These are the areas on EEG that were involved really quickly within a second or two of the onset of the seizure. So these need to be removed as well. Now, this is getting quite close to the corticospinal tract. So with tractography, we visualize the corticospinal tract in 3 dimensions. We visualize the lesion, we visualize the area to remove, and we map out on the surface of the brain the area we're asking our surgeons to remove in relation to the overlying blood vessels. The operation is made like this, and you can see that this is done in IMRI, so the craniotomy is still open. That was the lesion. This is the area with area of active epileptic activity that's been removed, and the corticospinal tract has been left intact. So this patient is cured of the epilepsy and has no deficit. And how it looks afterwards, this is what I showed you before. This is the surface of the brain with the craniotomy, and this is the resection that has been made. And the corticospinal tract is just millimeters behind this. It allows us precise, accurate resections. Now, we also use mapping the important tracts of the brain to minimize surgery in other locations. This is an example of the optic radiation, where it's been mapped with tractography. It's displayed in the operating microscope, so the surgeon can plan to make the operation to remove the amygdala and hippocampus without damaging the optic radiation, and this allows the avoidance of causing a visual field defect. There are many tracts that we can now visualize. The corticospinal tract here in yellow, as it comes around, you can see the so they come around here, and then I'll freeze it for you. Okay, well, you can see the arcuate fasciculus, the inferior fronto-occipital fasciculus, the middle longitudinal fasciculus, all these important tracts that we want to avoid. So in a little more detail, here's the detail we can now expect to get of the corticospinal tract to map exactly where this is in relation to planned surgery. Also, we know that the inferior fronto-occipital fasciculus is very important for language function, so we can now map this into the navigation for surgery and avoid causing damage to that. We know that removing the piriform cortex is important to get a good chance of being seizure-free, so we can also visualize that in 3 dimensions. So we're asking our surgeons to please remove this piece and don't damage the inferior fronto-occipital fasciculus. So this is increasing the precision needed to a millimeter level. If somebody has seizures arising from close to eloquent area and we need to make a resection, we can also do that with the patient being awake. So here's the person who's talking on her mobile phone while she's having the operation, and her right hand is also being evaluated, and the surgery to the left frontal lobe is being carried out as she is speaking and moving the right hand. So if at any time her speech deteriorates, or if you can't use the right hand so well, the surgery can be stopped before any damage is caused. So to summarize the outcome, temporal lobe resections make up 70 to 80% of all of our resections. About 70% will go into remission, and 40% will be seizure-free forever and a day. And if people are seizure-free, there's a big increase in their quality of life. We need to remember, though, however, that there is the risk of deficits. The visual field defect may be 5% nowadays, reduction in verbal and visual memory, and a possibility of a psychiatric disturbance. After a successful amygdala hippocampectomy, this is what we expect to see on a post-op MRI taken 3 years afterwards. Now, for people for whom resective surgery is not possible, there are palliations that can be used, such as vagal nerve stimulation, where the pulse generator is placed on the left side of the chest, connected to the left vagal nerve, and about 30% of people have a 50% seizure reduction. Seizure freedom is very rare. There are some adverse effects: hoarseness, coughing, discomfort in the neck. Over time, seizure suppression and mood and quality of life often improve over 2 years or more. This is how it looks, and this is the lead that we go from the pulse generator up to around the vagus nerve. Now, neuropsychiatry post-operatively is important. If one proactively asks people, probably about 2/3 of people have some form of anxiety or mood disorder in the months following surgery. And for 56%, this lasts for more than 6 months and then usually recedes, but people may need psychiatric help during this time. A more serious condition, psychosis, develops in about 3% of individuals who have had temporal lobe resection. Now, in terms of putting this in context, if we look at everybody who has pre-surgical evaluation, just over half, 51% at our hospital, don't go ahead and have operations. So just under half of people either have had surgery done or they're waiting for surgery. So, and what are the reasons for not having surgery? Well, it may be that about 1/3 of people, despite our tests, we can't localize where the seizures are coming from. About a further quarter, 23%, the seizures come from more than one place. There isn't a single source. And some patients decline intracranial EEG, some decline surgery. So that's 28%. About a third of people we say surgery is possible, we can look at this further, and the person decides themselves that they don't want to do this. Also, there may be a high risk of morbidity, say motor, language, memory, vision, or other. So I think altogether, probably if you put it into thirds, a third of people you can't find out where it comes from, a third of people it's multifocal, and a third of people the risks of surgery, either to ourselves or to the patient, is not acceptable. And of those people who don't have surgery, about 5% may go into remission with further drugs over the next few years. 25% may have a more than 50% seizure reduction, either with medication or with vagal nerve stimulation. And as I said earlier, people who've had evaluation for surgery, haven't been candidates for resection, and go on to a vagal nerve stimulation, 36% will have their seizures reduced by half. After the surgery, if somebody is seizure-free, would normally reduce the medications at 1 year, aim for a single drug at 2 years, and at that stage discuss with the person whether to stay on one drug or whether to try and come off all medications. And if somebody stays on medication, the risk of a seizure in the next year is about 10%. If medications are totally withdrawn, the risk is higher, about 25%. Now, in the long term, of people who are seizure-free in our series, 29%, just under a third, choose to discontinue medication, 2/3 prefer to remain on something. More women are more likely to want to come off medication as they're concerned about maybe taking medicines through pregnancy, but driving is overall the most important factor of what people choose to do. So in conclusion, refractory focal epilepsy is a common problem. If somebody has adverse effects from medication, we may recommend to do surgery. We need to look for concordant investigations, video EEG, MRI, psychology, psychiatry. Also, we need to consider the risks of surgery against no surgery, and in general, the risks of a procedure is similar to the risks of 1 to 2 years of the epilepsy as they currently have it. So I thank you for your attention, and if the chairman allows us the time, we can take a few questions.
Thank you, John. If there are any questions, please do type in your questions through the chat box, and I'll be happy to post them for you. Right. Since it might take some time, if I may, can I ask a few questions, John? Yeah. I think, sorry. So we've already got a question from Professor Jitangi Vanikasinghe. Right. Thank you for the great lecture. How long would you trial medications before choosing surgery as an option?
I think that's a very good question. I think in general, we would advocate somebody would try 2 or 3 medications for their epilepsy, for their focal epilepsy. And generally that takes probably about 2 years. So somebody may present with focal epilepsy. Maybe we do a scan, we see, yes, there is indeed hippocampal sclerosis or cavernoma. We might try, say, levetiracetam, then we might try lamotrigine, then we might try oxcarbazepine. And if those medications are ineffective, that's the time to go for surgery. Or at least to consider the possibility of surgery by doing the relevant tests.
Yeah, thank you, John. Like in the UK, I think the main, for the last, since 2017, we've had a few epilepsy surgeries in Sri Lanka, approximately 30 plus surgeries. But I think the main problem is, like in the UK, getting patients referred for evaluation is one of the main barriers. Is there anything that we, try to convince people to refer, patients for epilepsy surgery?
I think this is a real issue, and I think 18 years is an awful long time. And I think 18 years to have, and if somebody has epilepsy starting age 12, if they get surgery when they're 14, 15 years old, this is an illness they had in a short period of their lives, then this is behind them and life goes back to normal. If they have epilepsy for 20 years, they have surgery when they may be 31, 32 years old. By this time, they've missed out on normal adolescence. Their education and living away from home has been disrupted. Maybe meeting a potential partner, settling down, getting married, having kids. A lot of these things have been disturbed. And to try and pick those things up when you're 32 or 33 years old is actually very difficult for people. And people often may be very disappointed. I can certainly think of people who have had epilepsy surgery in their 30s, and on paper, it should have been a great result. They're seizure-free, off medication, but the person isn't so happy because life is not normal for them, because they had 20 years of epilepsy, and maybe they couldn't drive, they didn't get a boyfriend, didn't get a girlfriend, college didn't go so well, they didn't get a job, they're still living with their parents in their 30s. So doing it earlier really is better. I think we need to keep on going on about this message. I think in this country, a lot of work's been done with pediatricians, getting them to refer patients sooner rather than later. As an adult neurologist, I commonly still see people age 17, 18, when they're handed over from pediatrics, and you could see the person was a good surgical candidate for the last 10 years, but they never got referred. There's a lot of work being done to refer, also to educate patients. But no, we need to be realistic. I mean, neurosurgery does carry risks, and we shouldn't. I think there's a very good, if I can summarize it in one line, epilepsy surgery, underdone but oversold. Some enthusiasts try and sell epilepsy surgery, maybe particularly in the US. They try and sell epilepsy surgery like they're trying to sell a used car, We need to be realistic with our patients and give them a realistic understanding. But I think with a clear understanding, many patients will decide it's for them. But also, some people will say, well, if I'm having one seizure a month, I live in the city, I don't drive, I don't want to drive, the idea of having an operation that could possibly harm me without a guaranteed cure is not for me. And that indeed is the case. I showed you that 1/3 of people who get evaluated choose not to have surgery. Now, I have to say, people may say that, but a fair number of these people we began doing this in 1990, 31 years ago now. So a fair few people would have come along, maybe 17, 18, and then their mother say, no, I don't want to have surgery. They come back 10 years later and say, well, maybe I'll do it now. So people do come back, and of course, that's entirely their prerogative.
Yeah. We've got another question. Which groups of epilepsies are candidates for subpile resections?
In short, I would say none. We went through we tried doing some bisubpile resection. I think do you mean subpile resection, or do you mean subpile? Do you mean subpile
transections? Yeah, subpile transections. I'm sorry.
Yeah, transections, I think we did them. Yeah. The results are very disappointing, actually. So I must say we've stopped doing that. The theory was that if you had an eloquent cortex and you make these vertical cuts, you could disrupt the lateral spread of the seizure discharge without disturbing the function. I must say the results with the passage of time has actually turned out to be very disappointing. So I think us and I think most other centers have stopped doing this.
Again, a more technical question. So the majority of patients, even worldwide as well as in Sri Lanka as well, a lot of patients end up with temporal lobe resections because of the prevalence as well as the outcome, highest outcome with regards to temporal resections. Would you recommend the type of surgery? Would it be an anterior temporal lobe resection standard, or amygdalohypopectomy? Which how would you compare the two procedures with regards to outcome?
okay, if somebody has a lesion, and if you have a normal hippocampus, we would often recommend just simply doing a lesionectomy. And if that doesn't work, one can always do a second procedure 6 months, a year, 2 years later to complete the anterior temporal lobe resection. For people with anterior with hippocampal sclerosis, like the imaging that I showed you, I think we have a bit of a blended approach now, where the surgeon, rather than, because I think one wants to avoid damaging the optic radiation, one wants to avoid damaging the tracts like the inferior fronto-occipital fasciculus that are important for language function. So that's quite difficult to do that with a selective amygdala hippocampectomy because of the approach to it. So the way our surgeons have evolved it is that they take off the temporal pole, they resect inferiorly and anteriorly to go underneath the optic radiation and come up medially, remove the amygdala, the piriform cortex, and the and hippocampus, and usually take that back about as far as the mid-brainstem level. So it's kind of a halfway house. And I think in general, it gives us a good compromise between seizure freedom and lack of morbidity. The other thing perhaps to mention that is just coming on is the laser thermal therapy, whereby a probe, you may remember I showed you a recording electrode going posterior to anterior along the length of the hippocampus. That trajectory can be used for inserting a laser probe that is 2 millimeters across, right to the anterior hippocampus, and then emitting laser light and basically burning out the amygdala and the anterior hippocampus. And that doesn't damage the neocortex at all. And the results are, so far in the US, seizure freedom is not quite as good as with a standard surgery, but the effects on memory and language function also appear to be less. And of course, the person doesn't have a craniotomy, the risk of infection is less, the pain is less, and somebody would be in the hospital usually just 1 night rather than 3 or 4 nights, and they'll expect to get back to normal functioning within a week to 10 days rather than 2 months. That's something that we hope to introduce this in the UK in the next year, but the COVID's rather delayed everything else happening.
We've got another question. Thank you for a very comprehensive lecture. What is the place of VNS in a failed epilepsy surgery? Is the question.
I think it's the same place as if people who are not candidates for surgery. So if somebody has they've had a resection and it's failed, or if you've done the evaluation for surgery and you decide that it isn't the right thing to do, VNS is a very reasonable measure, and about 1/3 of people will have their seizures reduced by half or more. It's very unlikely that somebody will become seizure-free. We've done 260 vagal nerve stimulations, and we have 2 patients who are seizure-free. So that's under 1 in 100.
With regards to stimulation devices, there are, apart from vagal nerve stimulation, there are other types of stimulation, which includes deep brain stimulation of the anterior nucleus of the thalamus, and there is also RNS, responsive nerve stimulation, neurostimulation, like the NeuroPace. How do those devices compare with each other?
Yeah.
With regards, in the US, there's this hype on RNS, NeuroPace, and so on and so forth.
It's not a hype, I must say. When I did a review of this for Neurology, and actually the outcomes of VNS and RNS are virtually the same. And for deep brain stimulation into the anterior nucleus of the thalamus, it is said that maybe as many as 8% of people may become seizure-free with time, but it's much more expensive. It costs about, in US dollars, about $50,000 US for a deep brain stimulation, which is very expensive. For only 8% becoming seizure-free. So because of the cost-benefit analysis, it isn't approved for use in the UK because it's too expensive in terms of the benefit. So I think it may be that other intracranial stimulation paradigms will increase the success rate. I hope that's the case. And it's not entirely clear to me. In fact, I don't think it is the case. With RNS, one thought initially that if the stimulating electrodes are very close to the focus in exactly the right place, that will be more effective. It turns out that's not the case. And so long as the stimulating electrodes are in the same hemisphere, it doesn't really matter exactly where the electrodes are. At least in terms of the stimulation. Of course, you need a recording electrode near the focus to pick up the build-up of the seizure activity.
Okay, John. I think time is up. Thank you very much, John, for joining your talk and helping us through last minute. Appreciate it very much, and thank you very much.
Bashar and friends, it's delightful to talk to you again. We had a very enjoyable visit to Columbia for the College of Physicians some years ago, and this is a good way to remember that. So thank you for having me.
Thank you very much. Thank you. Bye-bye.
Bye.